right. Good morning. Hello, everyone, and welcome to the breakout session. We're thrilled to have you here. And my name is Steve. I'll be your room host today. Welcome to everyone joining virtually as well. A few things to note before we begin. This session is titled From Barriers to Bridges, Transforming Mental Health Care for the LGBTQIA plus community. It's presented by Rebecca Duffy, evolvedMD. We have an hour session and includes some Q&A at the end, questions and answers. So feel free to jot down your questions, drop them in the chat. Some housekeeping items, please make sure your phones are on silent. If you need to step out, feel free, but kindly do so quietly to minimize disruptions. We encourage participation, so if you have a question during the session, please raise your hand and I will call on you. For those joining virtually, please use the chat feature to submit your questions. And for those wanting to obtain CEs, this is new this year, please scan the QR code in the back, follow the instructions. Now you're going to have to log in, create an account, follow the prompts, and then certificates will be generated automatically. Now, with no further ado, it's my pleasure to welcome Rebecca Duffy.
Thank you so much, Steve. Well, good morning, everyone. Is everybody planning on getting CEs? Because I'm a stickler for making sure I get credit for my conferences. Should we pass the scanner around? Did everybody scan on the way in? You did. Okay. Okay. We can pass it around if needed. Okay. So thanks for choosing to spend an hour of your morning with me. I'm Rebecca. I actually work at evolvedMD, which I can see my office right on the second floor over there. And we are an integrated healthcare company. I know you've heard that before, but we have integrated into a majority of the doctor's offices in Maricopa County and into Tucson. I oversee all of New Mexico. We're in Florida, Colorado, Utah. So we are spreading our wings and making sure that we treat every patient with the respect and the dignity that they deserve. I am a licensed professional counselor, so I'm going to just be really honest. We're going to connect as human beings in this presentation, and I'm not just going to talk at you because I've done this before and it's not as fun that way. So being a therapist, I've worked in this area for about 18 years. I'm originally from Seattle, which you guys probably heard. I moved here to go to school, and now I've been here for almost 20 years. I've been a practicing counselor and clinical supervisor for about 12 of those 15, 16 years. So I like to say I'm seasoned, not old. I've led groups, I've done trauma work, substance abuse work, hi there, all kinds of therapy. And now I am more of a clinical supervisor and I oversee more therapists than I do therapy. I want to welcome. I just want to make sure everybody knows you can interrupt me at any time. That little tiny human in the back corner is my daughter. She's 9. A full sentence is rarely spoken. So if you need to interrupt me, feel free. You're having time. Do you want me to?
Good. Just want to make sure the recording was actually recording.
We can talk about it. So again, feel free to interrupt me. Let's talk. Let's chat. You're going to get some history. We're going to talk through some different milestones, and then we're going to talk through what's working and what isn't working. So our objectives for today, understand the role of mental and behavioral health providers, their roles, and then providing psychoeducation. We're going to identify risk and protective factors for young members of the community. We're going to identify brief therapeutic interventions that we can utilize in primary care. So again, why primary care and why is that part of what I'm going to kind of dig into? Well, a portion of it is because the one statistic I share, being from evolvedMD, is 64% of people that attempt to die by suicide have seen their primary care doctor within 30 days, which means still, and for all of us that have degrees and law, things that we're paying off, still mental health providers in the United States are your PCP. They are the de facto mental health care providers. We're getting there, but that's what happens. So we're going to talk about those brief interventions, and then we're going to identify 3 elements of the psychiatric collaborative care model that reduce barriers all kinds of barriers, but really barriers to care, access to care. Anybody in the room, it's okay if you don't, anybody in the room know how long it takes to see a psychiatric provider for a psychiatric assessment right now in Arizona? Wait times?
A month.
Huh?
A month.
Higher. Higher.
3 to 6 months.
3 to 6 months at any given time. Right now, we're at about 4 months, which means if you had something going on and you really knew that medication was going to help you, or say you fell off your insurance or something went awry, to go get a new assessment is going to take you almost 4.5 months. Okay, that's far too long, right? That's far, far too long. And just so everybody's aware, in Albuquerque, it's 6 months. That's my other department. Ooh. Not great. So let's talk a little bit about, let me ask this question. You don't have to raise your hand, but if you currently have a PCP at providers like Honor Health, Evernorth, oh, wow, that's perimenopause kicking in real quick there. Evernorth, Cigna clinics. In the state of Arizona, we have all but monopolized the community of PCPs. And so if you go to a bigger provider in Arizona, ask if they have collaborative care, ask if they have a therapist, because I bet you were in there and we can start seeing you or anybody in your family. So a little bit about the history. Who wants to tell me about the Stonewall riots? Who knows about those in here? Please, do you mind?
Yeah, actually, the one that happened 2 years before that was Compton's Cafeteria in San Francisco,
Okay.
which was really the beginning of it. It was the Stonewall Inn, where the drag queens said enough is enough, and they fought back against the police who were, harassing them for no reason whatsoever, other than the fact that they're living their truth.
Right, absolutely. Thank you so much. And that was in 1969. You said the first event was 2 years before that?
Yes.
Okay, thank you for teaching me.
Everybody forgets about Compton's Cafeteria.
Compton's Cafeteria.
Yeah, it was a gathering place for gays and mostly drag queens. And here again, it was the drag queens who stood up and said, enough of this shit, we're not taking it anymore.
Yeah. I like to start with this slide in the history because every piece of this slide changed the way and paved a way for something to be different. Whether it was positive or negative, it did pave a way for something to change. Like this thing right here. Okay, we're gonna get through it. So 1973, thank you APA for removing homosexuality from the DSM and opening the way to new understanding. However, that's great, right? That's not that long ago, just so we're all very clear, okay? And so people are like, oh yeah, that's a big part of it. Like, that's a big deal. It's like, what is that, 52 years ago? That's not very long, okay? And then we continue on. Was my math right there? Okay. 52, yeah. We continue on, Supreme Court decision in Lawrence versus Texas. Does anybody know about that stepping stone? Anybody want to share what they know? Do you know? Errol?
Oh, no.
No, okay. All right. Oh, also something to mark. I'm not even bothering to look at my notes. In psychiatry, 1973, they talked about how the APA removed homosexuality, which led to new studies that paved the way for new understanding and treatment of the LGBTQIA community. But that wasn't as simple as it sounded, because barriers were put in front in any way that they could be put in front of the community they were, because nobody wanted that to move forward, right? There wasn't enough backing at that time. So something that we want to consider as we continue to go through the timeline, which I wish you could see more of, is that we understand that when politics now, yes.
I'm gonna help you move that out of the way.
Yeah. What's your name?
Curtis.
Nice to meet you.
Nice to meet you.
You're from here on out, you're gonna be the tech guy in
Yeah, sure.
the presentation. We're glad you're here. Don't stop sharing though, Curtis, because these people from home are gonna get mad at you.
Just really sensitive.
There we go. Nice work. You know what you're gonna get for doing that? A CEU. Okay, back to what we're doing. Now I gotta find my place because Curtis was so kind. So again, and we don't need to talk about politics today. That's another breakout session for another situation. But we do know that when advancement starts to be made historically by groups that are a minority, things get put in place to block them. So this is very, very, very truncated, right? This is not a whole history. But as we continue on, you're going to see that many Supreme Court decisions where somebody said this is not okay, just like what you talked about with Compton's cafeteria and Stonewall, people stood up and said, I'm not doing this anymore. And so within that, more and more backing has come. But as you see here, we're still doing something in 2015, right? So this is not, this battle is not over. And that's why as a therapist myself, it's really important that we recognize the needs of different minority communities. Okay. The other thing I meant to tell you guys is, to interrupt me. If you have more knowledge, okay, here's what you need to know about me. I am very much forward thinking in the way that I know for sure I'm not the smartest person in this room. So that's a lesson learned, especially when you have a child. Who's showing, that looks good, bud. Showing me a picture right now. So if you have more knowledge on something or you want to contribute, please do so. Because this is the stuff that I'm going to present, but there is so much more. So National Coming Out Day, I think that this is a pretty amazing situation. In 1988, so these vibrant purple letters went out and that became National Coming Out Day. And bumper stickers with NCOD logo, pamphlet of ideas about how or why to come out as gay or lesbian, and a commitment card. A commitment card. How cool is that? If who you are, if your truth was not recognized or it wasn't supported, and then you get this, you can move forward in your own fight, right? So the personal declaration and part of the fight against the government was to say, well, here we are. This is who we are and this is what we're going to do. Does anybody know, is it up there? Who knows what National Coming Out Day, what day it is?
October 10th.
10th or 11th? Yes, you got it. Okay, so let's talk about the National Coming Out Day, NCOD. It was started in 1988 by Jean O'Leary, a lesbian, and Robert Eichenberg, a gay man, on the theory that LGBTQ people were so ostracized from society and that AIDS was not a priority, partly because most people didn't realize their own brothers, friends, uncles, and colleagues were gay. So you guys will notice that, oh, that's an evolvedMD fan. That's the company I work for. Good job, Emily. So you will start to see that I will go over there and I will read something because otherwise I just want to talk with you and I'm not going to give you the correct history. We're going to get to the talking part. But again, 1988, that's not that long ago. We're in the midst of the AIDS crisis. People around the country received the envelopes. This is NCOD, National Coming Out Day is created. So you signed your name on carbon paper proclaiming that you were gay or lesbian, and then you send one copy back to the NCOD headquarters and gave them to another, and gave the other one to like another trusted friend. And this then compiled the commemorative journal listing the names of all the respondents in 1988. Okay, so I was a child in 1988, but I can tell you that again, that's not that long ago, but also that's a really big movement. For it's an advanced movement in 1988, right? Because these people are coming through and saying, not only do I identify as gay, lesbian, bisexual, questioning, but also I'm willing to commit to it and I'm willing to put it in this journal. And at that time, the stigma was so huge that that was a very, very big commitment, a very big thing to do. So one of the things that happened was another forgotten court case or another forgotten milestone was when a teacher in California was persecuted for being gay. So this was in an era when thousands of gay men had already died of the AIDS epidemic, which the Reagan administration and Congress were unable and unwilling to prevent at a time when you could legally be fired or denied housing just for people who are identifying as queer. These LGBTQIA folks were being asked to take an enormously brave step to sign their names again to the public proclamation that they had committed to. So I'm just gonna be really forthright and transparent. This slide really pisses me off, but we're gonna get through it together, okay? We won't go through it note by note because I have a feeling with the folks that I see in here and the folks that I've already talked to, some of you know a lot about this, but LGBTQ, unfortunately, as a therapist, you see the timeline of when the diagnosis changed. Okay, so 1952 is the year my mom was born. Sociopathic personality disturbance was the first diagnosis that LGBTQIA fell under. You move up to 74, we're talking 22 years later, replaced with the category of sexual orientation disturbance. Keep in mind that this word, pretty gross. 1980, ego dystonic homosexuality replaced the DSM-2 category of sexual orientation disturbance, introduces gender identity disorder. Okay, so we're gonna take a small right turn here on gender identity disorder, because as those of you in the room know the DSM, and if you don't, it's still eons behind where society is, okay? I mean, there are things in the DSM-5 TR, I remember being like, this is it, I've got a lot of hope. And then we started reading into it, I think in a group supervision, and I was like, oh, man, what are we doing? So you go to the DSM-3R, and then here's the DSM-5. It included a separate non-mental disorder diagnosis of gender dysphoria to describe people who experience significant distress with the sex and gender they were assigned at birth. What's missing here? What's missing here? Read through all of what you see here, and then this kind of goes a different direction. So in the United States, when the DSM-5 came out, it was like, wow, look what they did. We changed. No, you didn't. You didn't change that much at all. There's not a recognition in this diagnosis that says that there's nothing in the DSM that notates nurture, that notates preference, that notates community. There is nothing like that. It just breaks it down again into gender identity disorders or gender identity confusion. Well, that's not what many people are dealing with. There's no confusion. There's no identity issue. That's not where we're at. Catch up already. I'm a therapist. I could literally sit down with somebody and I could give them that diagnosis. That's still so far behind in 2025. We've advanced so far. Now, granted, what? The DSM came out in like 2022? Yes.
So that's the American
Yes.
model. So is there something similar to this internationally, or what do they see?
That's a great question. So yes, this is US based. There are ICD-10 codes, which is a more universal code, but it's better. I mean, I guess too, like I'm being a little bit of a narcissist up here and thinking that I could do it the best, but it's better in the ICD-10, but it's not great. I mean, it's not where we need to be, I don't think. And then also it's hard internationally, globally, because there are still many places in different countries that don't recognize homosexuality at all. So to bring it together to have something that's kind of combined or a better understanding is virtually impossible in that way. But I would say the ICD-10 is going to get you closer. So this is where I started my journey in therapy, was with children of the LGBTQIA population and working with their parents to understand who they still were with a child that was part of this community. And that was for me 12 years ago. And there was a lot of work to be done in that time because parents were still very much rejecting, not that they aren't today, but rejecting and feeling a sense of grief and loss amongst their children being part of those conversations. And that's just not how we can do things to care for a child as they're growing into who they are. I love this poster. So you see the mental health challenges that the children are going through, still today going through. And then we're going to talk a little bit about these rates of suicide, because non-acceptance is one of the leading causes, no matter your age, of attempted death by suicide. Okay, so risk factors. I think some of these go without saying. But, well, we're gonna start at bullet 2. I don't do things in order anymore, I've decided. Bullying and discrimination. So I made it really clear, the child in the back is mine. She goes to school. Not having a group of people in the school system opens you up at this point in the United States, not every school, but not having a group to belong to, cruelty escalates so quickly. And I frankly, I mean, no offense to those in the room, Emily, cover your ears. Kids are assholes. Like, they are really unkind to those that don't fit. Emily's like, you're right. And so, I go through that all the time with now she's listening too. I go through that all the time because if you don't belong and you don't look the right way or speak the right way, or you just aren't like a cool kid, you are rejected immediately. And so we're working with these children in a population where their parents look different, and kids are smart. And so their parents, their situation, their home situation, whatever it is, looks different. And then they are rejected in the schools outside of already not knowing exactly how to understand and orient. I had a client a few years back and she was 5. So orienting the world at 5 was already really difficult. And then her parents loved her so much, but she'd go to school and they did everything they could. She'd go to school and get bullied. Well, now we've got 2 factors pushing against us really hard. And these are little kids, okay? So we can go into discrimination. Oh my gosh, you guys, it's already 10:52. I have 39 slides and we're on slide 9. I'm gonna have to move a little bit more quickly. The stress of just being part of the community, it's stressful because of the rejection, they're harassed, discriminated against. And then we also get down to being addressed by wrong name pronouns. Okay, so I worked in the Arizona mental health system, the state system, for quite a long time. You would be amazed, or maybe not amazed at all, and severely disappointed in the amount of people that cannot wrap their brain around one name versus another name and what somebody prefers to be called. It is really gross and disgusting. This is not a hard problem to solve. I can tell you right now at evolvedMD, it is name on the birth certificate, preferred name, all of the things broken down, because you as a patient, a client, a human being deserve to be called what you desire, what you want, what fits you on the inside. This is not a problem. And yet we still have this all of the time. And as a child, if somebody comes in and they're 13, I have I guess she's my, second generation niece. I don't know. Families are hard. But she's decided, she says that her name is something different. She wants to be called by that name. Everybody, this is a family I'm divorced from, still calls her the old name. And I'm like, what about that is challenging for you in the way that you're showing up? So discrimination is everywhere and our kids are feeling it. Clearly, we have big issues still with suicide. We have big issues with that discrimination piece. But how do we protect our kids? I love this so much. So unconditional love is the biggest factor. There shall never be a condition in which someone's sexuality comes up and is based on their love is based on that, right? Unconditional love is key, biggest factor. Network of supportive adults. This has become a bigger and bigger issue in society because we separate to protect ourselves. And in the last 10 years, it shows that community is scary. Sometimes community is scary, so we stay away. We just create our small little circles because big community events, it's bound to be someone that doesn't agree with you. At some points, it's very dangerous. For many people, they won't go because they don't know who's going to be at a big community event, so things change. What do we have to do then to replace that situation of a large community? We need to replace it for kids with other supportive adults. And so you'll see, things like the free hug situation, but that network of supportive adults, if you're sitting thinking, I thought about this, who were my supportive adults when I was younger? I don't really know if I had somebody as an adult, as a child, who was an adult that I could go to with any issue and they weren't going to just tell my parents how to fix me, right? So this is somebody that your child should feel safe with, obviously, but able to talk to. So therapy's cool. Attending schools with supportive policies. Yeah. think that goes without saying. I mean, the bullying is already happening there. So if the school itself doesn't support your child, we need to move through that. And us as, you know, in the state of Arizona, like my manager in New Mexico says, New Mexico does everything bad really well and everything good really bad. And so supportive schools and money going into schools is something that they don't have, and Arizona is not super far behind. I think that we have advanced in that way, but things need to be done, more things need to be done with school support for sure. Good healthcare, and then being able to use their preferred names and pronouns. Good healthcare. Side note. Anybody, well, somebody knows. So somebody just shout out, how much what is the out-of-pocket expense on average to see a therapist in the state of Arizona? On average.
$20.
120? Love that. I'd say between 120 and 160, depending on their specialty, right? Now, I don't know about you, but $160 a week for me would be a little spending. So when I go present the program that I help run, I often say, as a therapist, if my doctor were to hand me a referral card and say, you need to go to therapy, I'd say, okay, we'll put that off the list. Got about 15 other things I need to pay for or do before that. So access to care is a huge barrier for the children and for the adults. We're going to talk a little bit about how do we get good health care to those that need it. And no, I can't solve the national problem. Just talking about here and mental health care. So current climate for children, the pandemic was terrible on everybody's mental health. Children couldn't navigate it. I couldn't imagine having been my child. I was an absolute mess. I'm sure she was like, is this your first time parenting? Because you are not nailing it. Unfavorable legislation every day. We see things change. We think things are moving forward. We take 3 steps forward. We take 19 steps back. Things are not going in the way that we needed them to. And so again, politics, I'd love to, but I can't. Trevor Project poll results. So participants ages 13 to 24. This is within the LGBTQIA community. 73% experience anxiety, 58% experience depression, 45% death by suicide. 1 in 5 transgender youth actually attempt to die by suicide. 1 in 5 transgender youth. There is no other population with a statistic that high for children and suicide. 1 in 5. Because we can't, as a community, bring ourselves to to speak to somebody in the name that they prefer, with some added understanding of what somebody might need. I get really angry in presentations sometimes. It's starting to happen. So why, at this point, what are we going to do to help at the baseline, right? So we often say, I'm going to go back to this for a second. We often say healthcare needs to be accessible. We need to have these kinds of programs. I'm going to just put this in our ears, and I want us to think about it when we get to the end. I'm hoping we have time for conversation. What are the preventative steps? Okay, yes, I can't give everybody free healthcare, but there are things like community programs, resources. Start to think about, before we have this part of our conversation, what is the preemptive care for these children? What do we need to do before they start to feel these things? It's a little vague, it's a little broad, but I just want you to think on it, because at the end, I'm hoping we can talk a little bit through what can we in this room do about this? Because this number is also extremely high. I can only think of one other population where, and again, this is one poll, but I'd say it's pretty close to true from everybody that I've treated. Okay. Questions, comments? Is anybody like, is she going to get into anything else but history? No comments? Yes.
One thing we could do that's not just have kids go to therapy is just have a trusted adult or like a friend that understands to talk to without them interrupting. Just have them listen while you pour your heart out.
Yeah. Do you know why I feel really lucky today that you're in this room? Because I don't think I've ever done this presentation with a child in the room. And I mean, you're clearly a grown up. I don't know who the guy is next to you, but you are nailing it. Non-judgment is one of the only things we can do that we don't have to spend money on, start programs on, do anything. You're right, Emily, you're absolutely right. Yes.
I'm in the legislature, and
I hope I didn't hurt your feelings this time.
No. I support that. Sure. crazies over there make me crazy because we
We're-
need,
we are
we
on the
need,
same.
we need people to come and speak up for the youth.
Mhm.
And we've been depending a lot on the youth to come in and speak up for themselves. And they do a great job, but these adult legislators they just don't hear. They just don't want to understand these kids. And, they want to call them by their dead names. They
Right.
want to, demean who they are.
Right.
And it's just so infuriating. This just makes me so mad.
Yeah, I'm with you, but I have to control myself. You stay mad. You and I'll get together after. I agree with you. I mean, until it happens to someone, until one of these things, they go through it themselves, it's another number. And I'm not saying that to the people in this room, because clearly you have passion, concern, we're here together. But I think you're absolutely right. When do we see change? Well, so-and-so's child did this, or so-and-so's, child committed suicide or died by suicide. And we don't want those things to happen, but how do we make people listen? So, Emily, we're going to talk a little bit more about what you said and how we keep an open mind, because that's the first thing we can do as human beings without having to. You can go out and listen right now. There's not a lot of preparation to do that. You have to be a trusted person, though. Okay, so the median household income for married same-sex couples was $107,000 in 2019. If you have more than one child, that is difficult. That could be difficult, right? Getting kids involved in more programs cost money, that can make it more difficult. And this is 6 years ago, and I'm positive that life has gotten a lot more expensive since then. So now we're dealing with another layer of problems, right? Money problems. Kids feel that. 14.7% of same-sex couples have children in the household. So here's your piece. Lesbian, gay, bisexual, or transgender respondents were more likely than non-LGBT respondents to experience economic and mental health hardships during the COVID-19 pandemic. I don't know why we say COVID-19 pandemic at the end of that. That is just a variable truth at all times. Not necessarily with the money part, but mental health hardships is what the entire presentation is about and how we're going to bridge that gap. So competent care. Ooh, okay. We don't have time to go into a big conversation here on this one, but would there be anybody in this room that is, again, I said we were going to connect on a humanistic level. Is anybody willing to share a time when they had a provider that was culturally competent and how that made you feel more comfortable, or was not culturally competent and how that affected you? Please.
One of my best psychiatrists, which later on I became a coworker with gay, and he was looking for gay clients. So we could get past that issue and talk about my bipolar instead.
That's fair.
Which was nice. I really enjoyed it. He was a great doctor. I still learned a lot from him from our sessions with him. And later on, I got to work with him at UPC, where he was the doctor on staff, and I was there as a BHT and peer support to teach classes and stuff like that. So
that's amazing.
nice.
So got past the preoccupation of who you were and actually talked to you about the stuff that you were there to talk about.
Yeah.
How relevant in mental health care. Who else? Any other stories? Yes.
I am an ER nurse. I used to be at Phoenix Children's, and unfortunately, on the negative side, Phoenix Children's, at least when I worked there, would put pronouns. And there was a provider that was like, that's stupid. Why are they putting that there? It doesn't. I'm like, oh no, but it does matter. And it does make a difference in someone's face, their change when you ask them their pronouns and use them. It makes such a huge difference, and they can open up and actually, again, like you said, get past a gender barrier, whatever it is, and move forward with actual healthcare.
I still to this day don't understand why somebody wants to be referred to as they or them. But you know what? It costs nothing to be respectful.
That's exactly.
And if that's what they want, correct me once, I promise I'll do my best.
Yeah. Did you have a comment?
Yeah, I too have an ER nurse by history, and I started my career in the middle of the AIDS epidemic. So people were coming into the ICU dying of pneumocystis pneumonia. It's every day, but the piece of staff treating people inappropriately, and just black and white, redneck, whatever you want to call it. I don't believe what you have to tell me. Why are you here? Versus being able to say, look past whatever they present with from a social aspect or from a personal aspect, and why are you here? And how can we help you? It changes everything. And I evolved. I'm not going to say, and I'm not perfect, but that evolution finished. I'm still working, but not in that capacity any longer. With why don't you go talk to those people? You know what you think like they do. And I'm like, I'm okay with that because I know I'm going to be able to provide a better level of care than the person who just asked me to do that.
And also to put yourself in someone else's shoes, not that you could necessarily understand how they're showing up as a person, but to put yourself in someone else's shoes just based on the feelings they feel can get you very, very far. And I think this dialogue is important to me, and I'm really thankful for those of you that shared, because I think the other side that providers forget, right, is that the person that's coming into your office is just showing up as themselves. So if you are preoccupied with something else about that person, that is a you problem. So this now, your example, Bruce's example. He's going into his appointments or showing up for appointments with the ability to just be himself, right? And what he was telling us is, well, then I have to explain who I just showed up as. I don't have to do that. I show up and say, I got my own problems. And they just go into that. So I think that's something for providers, and that's really the cultural competency here, right? Is if a provider has to know more about how you're showing up instead of know what your blood work is saying, then they have a problem. Okay, thank you for sharing. Social and structural equality of care, avoidance of stigma and discrimination. So, and then provider and patient language, you hit on perfectly, right? And I experience that on a regular basis, and I'm sure some of you do too in different various workplaces. Oh, that's dumb, I'm not going to do that. Well, you're one problem amongst a whole colleague of people at a very big hospital. So you've got to start to educate and go with the flow, evolve, as you said, right? This guy's face describes my feelings a lot. What did you just say? So language sets the tone. I mean, this is what we were just talking about. Ask the patient for their preferences. It costs no money. It takes 1 second. It's nothing off of you as a provider, right? And again, people are coming in to be who they are. So who are they? Like, ask that question and then we move forth, but they deserve to have an answer to you, and then make sure you document it. That's the other thing, is for a long time it was, oh, we asked pronouns, or, we did these things. Well, is it documented in their chart? Does the next person know? Because that's not a defense that somebody should have to go through every time. We've all been in that place where it's like, especially like Phoenix Children's, my daughter goes there, and it's, like, start here and then you've got 16 more appointments in the same day. I don't want to fight that battle every time I walk into a different office with a different provider. So challenges to care. You guys already taught me about this today, but difficulty discussing sexual health related issues. This is part of what comes up, your experience amongst the AIDS epidemic. Many people in the, mid to late 80s, especially men, which we talked about earlier, people didn't know, right? The people around the support system, even their providers, didn't know. And so at that point, how do you discuss how you're feeling, what's going on with you medically? You just don't. And then we lost so many people. Unfamiliar with gender modification surgeries. This is huge. This is really a big thing to learn about if you are a provider. I will tell you, 10 years ago, when I was supervising one of my younger therapists, she taught me, and we learned together a lot about gender modification surgeries because they weren't as prominent at that time. And it's important to know and be educated in what you talk and what your clients, patients come into you with. Failure to be sensitive. I would say failure to be sensitive can just be its own bullet point, but we go specific here in addressing sexual acts or complications unique to the community. We forget as providers that we feel the same feelings, they just might not come up in the same way. Okay, so if I can't talk to you, I feel silenced, I feel small. Not because of my gender, not because of the way I'm showing up, but because nobody's hearing me. If you've ever felt small, you just relate it to my feeling, not my experience, and that's all we really need. Higher prevalence of anxiety, depression, stress, and then use of alternative medications, which is black market hormones are something that is still happening, still exists, happens all of the time, and is something that personally I've experienced with a client. And things went terribly awry, and I don't know that that person will ever be able to come back from the changes to their body because they didn't know exactly what they were getting, and it caused some severe physical distress. I want you guys to read through these on your own so that I'm not reading to you. And as you go through, be willing to just tell me which one of these bullets sticks out to you. What's the bullet that has meaning to it for you? These are solutions, potentially. Okay, I'll start. Not everybody at once. I will tell you that there are many different ways of being sensitive on this slide. I don't know what it is for me, but this is the one that sticks out to me the most. On intake forms, include the term partner in addition to the spouse, include transgender as an option. Spouse means I decided to do something in the legal system. You're my partner for life. You can just use partner. I'm not against marriage. Been there, done that, but I'm not against it at all. I think everybody deserves to be able to do that. But if you're my life partner, it's fine. It's fine. We can just put partner. But you don't see that at all. That is not something that is, well, it's more common now, but it's not as common as it should be. Anybody else coming in with a bullet that makes them stick? Yeah, Emily.
The first one.
The first one?
Promote acceptance of members of the LGBTQIA+ community.
Yeah. Yeah. We got to promote, right? We've got to show up. We've got to support. Brittany, I'm Rebecca. Nice to meet you.
Nice
What
to
do
meet
you
you.
got? Thanks, Emily.
I really like the last three of just kind of like, I think putting it out there, because you can have it in your head that I accept people, but that population doesn't always feel safe and they don't know that you're safe.
Yeah.
And I think putting that representation out there, they say, okay, I can be me and I can let you know who I am.
Yeah, and then I think too, we've come up with the term ally. Okay, I mean, I love everybody, or so I try to at least do my best. But as an ally, be loud and proud as an ally, right? Like, this is your belief system. You're right. Like, I definitely think that we could do a better job representing, like, I'm here, come free hugs. I'm here for it. Like, let's do that thing. Anybody else want to point out? Yeah.
For me, it stands out as the maintain open mind, avoid judgment. And then it goes on to regarding sexual orientation and practice. But if you just do that first part of that, with anybody you meet, and they can see, and that other person can see that in you with your actions, I think all the others fall into place.
I agree 100%. And I appreciate this bullet. I act like I wasn't part of the creation of this. I'm like, why did we put that? Either way, practices is one thing I just want to touch on briefly. You want to know something that I think is really funny? Is in society, it's not like straight people go out and are like, hey, this is what I do all the time in the bedroom, right? Like, it's not a comfortable thing to begin with. So I find it odd when people are like, that's gross. Like, you're just as gross. You just do something different. If it's all going to be gross, it's all gross, right? So when it comes to practices, if we could just be more accepting in general of the fact that everybody enjoys pleasure, that pleasure is part of who we are as human beings, that however we get it is the way we get it if we're not harming somebody else, right, or ourselves. So I think, that bullet point is important to say, what you do, it's just like it doesn't cost anything to call somebody by their pronoun. What you do behind closed doors in your life, I'm not there to judge. And I think that that's something that we can also be a lot more open with, discuss, advocate, defend, however you want to put it. Okay, so stigma and risk factors, we've gone over this. Oh, that's not. One of my employees is in this room and she's 0% shocked that I can't get the technology to work. She's sitting back there like, oh. Okay, so stigma can be internal and external. Anybody in the room know somebody that's gay that is so stigmatic against themselves that they can't actually take the steps to come out? Yeah. Internal stigma is so sad and so hard, right? Internal stigma can cause problems with self-acceptance, anxiety, and depression. External stigma, difficulty forming intimate relationships, and then being honest about sexual orientation or gender identity. If you know you're going to be judged on something, and you decide to step into that pool with no life preserver, good on you, because the world thinks that you're scary. And that's part of the reason we're in the room, right? Oh, that's too much. That's too much for me. No, that's not what we're doing anymore. Bisexual women, 3 times more likely to have a substance use disorder than heterosexual men. Transgender persons, 38 to 65% have experienced suicidal ideation. That number is so high in comparison to other minority populations that, again, we come back to what are we doing wrong? What are we doing proactively? How do we advocate? What do we change? COVID, I'm sick of talking about COVID. We're going to move through this one. Okay. Domestic violence in the community. This is an interesting discussion piece. And I almost always have a fairly high discussion within this slide because of a couple assumptions. So domestic violence does occur, right? It doesn't matter your gender orientation or your type of relationship. Transgender individuals have a higher risk of domestic violence. Why? Why do we think that is? Yes.
I get really different sometimes.
Yeah. I think that there can be confusion within a relationship into domestic or roles, and then roles get mixed up. And this is something that I've learned, not myself, but been taught by people in my audiences and or going to lectures just like this to discuss why. What's the 2 times more likely to experience physical violence? Well, it's courageous to be you, right? It's courageous to be the person that you are. And sometimes that pisses people off. Gay, lesbian, bisexual, and transgender victims may be less likely to report domestic violence. This is partially due to lack of support services such as shelters, support groups, hotlines, etc. If you're not accepted for who you are, why would you step out and say, hey, also I'm being hurt? If you don't love me when I'm regular, when I'm just me in the world, you then want me to step out into the world and say, I need your help because my partner's harming me? No. That's such a ridiculous expectation. If we can't be warm enough to accept, and then this person is being harmed somewhere else, what do we assume? What would you assume as this person that's being harmed? They don't accept me, so it's going to be my fault, right? Think of all of the things that are happening right now in the United States. If you're already not accepted, what do we do? What does the society do? Not everyone, but it turns it into your fault. So again, people die, right? Domestic violence is a big problem amongst this community. But if you don't feel accepted to be just who you are every day, stepping out and saying, this is happening to me, with the potential of somebody saying, well, it's your fault, is a really big expectation. So APA decided that they would give us some advice on best practices. Pretty sure we could have come up with these on our own, but let's look at the guidelines. Create an environment that is accepting and affirming. Assess the patient's level of openness and self-acceptance. Avoid so-called conversion or reparative therapy, and encourage families to support and accept family members of the community, especially their children. Now, I'm not putting down the Psychological Association, you know, I learned from them for a long time, owe them a lot of money in all realities, because that's what I did in college. However, this is rudimentary at best, no? Right? I mean, okay, like I'm a parent of a transgender child. Could you give me a little more here? Right? Like this is, but either way, we'll look at the guidelines. So creating an environment that is accepting and affirming. As a therapist myself, all of these things, all of these bullets are just build rapport. And remember when I started the conversation, I was like, we're going to just connect as human beings. You build rapport in relationships all of the time. That should be the goal. That should be the gold standard of what you expect from your providers in any healthcare piece. But yet the APA is giving you guidelines on it. We need to do better. I expect my therapist, my doctor, my ophthalmologist, because somehow I ventured into that. I expect all of them to treat me with respect because of the rapport or the reason that I'm there. So something that we don't consider, and we talk about this in our model, but don't worry, I'm not going to plug that here. But in our model, we often say, like, you coming in and building rapport is just the baseline of care, right? Like you get to expect that. And oftentimes as a therapist, we go backwards because we're wearing somebody else's hat because bedside manner doesn't exist anymore. 30 patients a day are what your PCP is scheduled for, most likely, 15-minute blocks. They're waiting for a no-show. They are just waiting for somebody not to show up so they can, like, you know, chug a protein shake and move on. That's not healthcare. That's not what we do. The 7 guiding principles are here. You don't have time for me to read through them, but I do venture to understand that most of you are reading them. It is important. Number 4 is important and not important at the same time, but let me explain myself. Sexuality is composed of 3 distinct realms: orientation and attraction, behavior, and identity. These 3 realms are interrelated, but not always aligned. 3? Just 3 sectors? I don't know how I feel about that. And then 5, gender may develop based upon biologic sex, but this is not always the case. Again, we're talking about our transgender, intersex, and androgynous individuals in our community. But these are the 7 guiding principles. I do really appreciate the first principle: gender and sexuality exist in continuums with infinite possibilities. Excuse me, infinite possibilities, because you are you and you don't have to be dictated or told exactly what you want to do within your relationships. All right. So as we start to close up, because we've got like 7 minutes left, and I'm sure there's questions, I want to make sure that we go through the affirmations, the things that are affirming to care. Mapping. So internal, external, embodiment, roles. Gender identity mapping is important, especially for our folks that are either, oh, you can have my whole slide system if you guys are writing stuff down. We'll send that out. Don't take notes. We're so past that. But gender mapping is really important because some folks don't know when things started, when they were accepted, were they ever accepted? Did they have an actual coming out? Was it forced upon them because somebody found something out? So in therapeutics, but also in being somebody's main support that you can talk to with no judgment, as our friend Emily told us, this is part of what is important to talk through if the person is comfortable. Mirror work for dysphoria. Mirror work is hard. But basically, when you are looking at yourself and you are working with patients or clients, mirror work for what do you see? Tell me about you. Guess what that person more than likely is going to talk about? What they've been told they are, who they are, how they are. And then they get to work with the clinician or their provider to reinstate what they are and who they are by looking at themselves and saying, this is who I actually am. And it is groundbreaking. It is something that is really affirming to the patients. Name and pronoun rehearsal scripts. Oh, I worked with a teenager at one point and we did this. And he got louder and louder. At the end of it, he was like, I am to go. And I was like, okay, you got it. You rehearsed that script. But it's important because somebody, again, has been told that they're not accepted. And then creative tools, get it out of your brain. Get it out of your brain. Look at it on paper, reread it, but journaling, rehearsals, my gender is like statements, things of that nature. I wonder how many slides I actually got through. Let's take a look. Oh, it's curious. All right, so I'm going to send out the entire presentation, and I apologize that I get passionate, want to hear from you, and didn't clear 10 of my slides. But for the people in the room right now, what questions do I have? I don't know what she said. Questions, comments? Okay, I was like, somebody speak up. You're going to let me off the hook.
I have a comment. I think the APA in that slide that you pasted on the APA, as basic as it is, it's missing from all of healthcare today. And I just personally had a health issue, and there is no report.
There's a report.
Yeah, I was in the hospital for 5 days, and I had one physician who actually touched me and actually sat down and talked with me. So, and I let him know, but that's and as a healthcare provider, it's missing today, and we can't get to the LGBT or the sexual issues or the mental health issues until we get to hi, I'm Pete, I'm your nurse today. How can I help you?
Right. Like human connection. Right? Like we have gotten so used to, hi, how are you? And Bruce is going to his rehearsal might be, I'm good, how are you? But I'm not going to stick around long enough to hear his answer. Right? I might hear anybody that says that. Taking the time to say, hi, Emily, it is so nice to meet you. What's your favorite this? That connection is lost. And that is the beginning of building rapport. Just ask something, know something, build some kind of relationship.
And not to put our legislation.
Like have questions for you because I don't know where you put it. I don't know where it goes.
I have one more comment.
Yes, please.
Not to put our legislator on the soapbox or on call her out, but the other issue is it doesn't matter if I'm a primary care provider and I've got 15-minute visits in my day, or I'm in the emergency department and I've got 110 beds that are already full, and I've got another 110 beds of ambulances and people in the waiting room. Someone has to pay for it. And whether it's paid for by the government or it's paid for by the corporations who's skimming 30 to 40% off the top, the money needs to be reappropriated.
Yeah.
And we need their help to change those things, because I can't change it at the bedside.
Yeah. And it's really, I agree with you. And it is really hard to expect somebody to be able to change it at the bedside when they have 15 minutes to get to know you, diagnose you, order your labs. Like, that's not realistic. It's not. My mom is in her late 70s. She has dementia. She hates going to the doctor because everybody feels like a stranger to her as it is, and nobody takes the time. So she's terrified of that experience, right? So, and it wasn't always like that. There were days when, you see if I have questions?
Yeah, I checked the chat. There wasn't any questions.
Okay. All right. So thank you for that. I appreciate that comment. Thank you for being my IT guy. Yeah.
Do you have any resource or anything where you've talked about these remaining 10 slides? Like, as a mental health counselor, I was like really interested in this part. I'm like, oh, I want to hear more about this. Like, do you have a way of connecting, maybe?
Do it right now. Believe it or not, it's where I work. Okay. So collaborative care. I'm going to give you a really quick synopsis. There's 3 main players in collaborative care. Your PCP, a psychiatric consultant, and you as the client, okay, as the patient. What's a psychiatric consultant? Well, it's part of the problem and part of the solution. So we know, as a mental health provider, that per most big mental health issues, medication and therapy together are what work the best, okay? I can give you all kinds of data on that. That's just where we're at. If you remember, we said earlier, 4.5 months in Arizona. If you have to wait 4.5 months and you're going through therapy, but you have to wait 4.5 months for medication that just could alter the way that your brain is working to get you through something, it's too long. So what collaborative care does, evolvedMD is where I work. I'll give you my card. We go into your doctor's office and we bill out under a physical healthcare code. meaning you're not tapping into mental health care or any of those providers. The provider is right there in your doctor's office. Okay. You pay the same copay you pay to see your doctor. So if you pay $25 for a physical, you're going to pay $25 for a therapist that's worth $200 and some dollars. Right in your doctor's office, remove that stigma, right? So you're going to the doctor, you're not going to your therapist. And your doctor, your PCP, can see everything that you've done within the electronic health record because that collaboration is happening in your file, essentially. So the resources that I can give you, yes, I have resources. Let me get your email. With that being said, you all are going to get this, but what we need to be pushing for, and the reason that I come and talk with people in conferences is if your doctor and your mental health therapist is not talking, we're already doing you a disservice, okay? If you go to bed at night, you can't fall asleep, I promise you that it's not just I have insomnia, okay? If you have digestive issues or you have stomach aches every day and it's your doctor says, I don't know what's going on. I promise you, I can tell you what's going on if you sit with me for 25 to 45 minutes, okay? Mental health and physical health are integrated. It is a full integration. So collaborative care is what you're looking for. And no, it doesn't actually behoove me for you to show up those appointments or anything. I just like you all very much. Thank you so much for your time. This will be out on the website. If you want to get your CEU hours, please scan the back. Otherwise, I really appreciate your time and have a really good rest of your Saturday. Thanks, everybody.